Good morning, friends. I'm Dr. ANUSHA, Senior Resident, Anesthesia Department. So today, our topic for today will be respiratory physiology. So before moving on to the slide, so let's go on to the slides. So regulation of breathing. So our breathing is mainly controlled by the major centers that are present in the pons and the medulla. So the pontomedullary junction is very important. In the pons, there are two centers, which are the pneumotaxic center and the apneustic center. Whereas in the medulla, we have the ventral respiratory group of neurons and the dorsal respiratory group of neurons. So both these group of neurons, they have separate roles. Like the dorsal respiratory group of neurons, its major innervation will be to the diaphragm and the external intercostal muscles. Both of these play a very important role in inspiration. So whenever DRG is stimulated, inspiration will start. Whereas the ventral respiratory group of neuron, it has its major efference to the accessory respiratory muscles and the internal intercostal muscles. So both these will control expiration. So whenever VRG is stimulated, expiration will start. So what is the function of this center in the pons? That is very important because those are the centers that in turn controls the DRG and the VRG. So apneustic center, it will stimulate the dorsal respiratory group of neuron, thereby it will initiate the inspiration process. Whereas the pneumotaxic center will inhibit the dorsal respiratory group of neurons and thereby it will stop the inspiration and start the expiration process. So this right side picture is a similar one, but it is a little enlarged. You can see in the pons, there are the pneumo and the apneustic center. In the medulla, we have the DRG and VRG. And all these, they receive their afferents via vagus and glossopharyngeal nerve. In this left side pic, you can see the efferents. So there are actually two mechanisms. One is the nervous regulation, another one is the chemical regulation for respiration. What we saw in the first slide was the nervous regulatory system. So the same thing we have put into words like in the medulla, in the pons, and this medullary center is actually the rhythmicity center. Okay. So this is a very important reflex. It's actually the Herring-Brewer reflex. It's a protective lung reflex which prevents the lung from excessively inflating. So whenever the lung is inflated at the end of inspiration, the stretch receptors in the wall of bronchi and bronchioles will stimulate. That will go via the vagus to the dorsal respiratory group of neuron. It will inhibit the same and it will switch off the inspiratory ramp. So inspiration will stop and expiration will start. Now coming to the chemical regulatory methods. Actually, there are three chemicals like carbon dioxide, oxygen, and H+, which plays a pivotal role in the regulation of respiration. So first, before moving on to the chemical regulation, we should know what are all the centers involved in this. Like in the nervous regulation, we saw there are the pontomedullary areas. Similarly, in the chemical regulation, we have centers both peripherally as well as centrally. So centrally, it is in the ventrolateral surface of medulla. Whereas when you see the peripheral areas, these are the carotid and the aortic body receptors. So you can see in this picture, the bifurcation of the carotid, we have the carotid receptor. In the arch of aorta, we have the aortic receptors. And these, in turn, they have their innervation via glossopharyngeal and the vagus nerve. So coming to the first chemical regulatory mode, which is the carbon dioxide. Actually, carbon dioxide, its action will be majority in the central chemoreceptors only. Carbon dioxide, when you plot the PaCO2 versus ventilation, it will be actually a straight line curve. So whenever our body has like 5% carbon dioxide inhaled, it will be an unpleasant feeling only. Whereas when we are exposed to more than 15% carbon dioxide, we will face muscle rigidity, tremor, and there will be a little bit of unconsciousness also in certain patients. When you go for a 20 to 30% of carbon dioxide, definitely there will be convulsions. Actually, this carbon dioxide, it will act on the central chemoreceptor, and its main role will be to increase or decrease the depth of respiration. So this is actually a flow chart which says like whenever the carbon dioxide content increases in the blood, this will combine with water to form the carbonic acid, which in turn splits to form H plus and HCO3 minus ion. Actually, this H plus only will enter the CSF. So whenever the CSF becomes acidotic, that will bar the CSF will also bar the central chemoreceptor area, right? So whenever the CSF becomes acidotic, that will stimulate the chemoreceptor zone. That will in turn send the impulses to the respiratory areas, thereby increasing the respiratory activity. So alveolar ventilation will increase. There will be expulsion of carbon dioxide. Thereby carbon dioxide level in the blood will come back to normal. So carbon dioxide increased. Finally, via all these steps, the carbon dioxide turns back to normal. So this is our body's response to hypercarbia. So actually the concentration of H plus is the same as we saw in the previous slide. Similar mechanism only. Now when we come to oxygen, actually whenever our body faces hypoxia, the peripheral chemoreceptors will get stimulated. So carbon dioxide, most of its action will be at the central area, whereas hypoxia or oxygen involved mechanisms, majority will be at the peripheral chemoreceptors. Actually not majority, the only response to hypoxia is from the peripheral chemoreceptors only. So whenever we face hypoxia, so these peripheral chemoreceptors are stimulated. Where are these? Yes, it's in the carotid and the aortic body. So this in turn will transmit the impulse to the respiratory center. There will be activation of respiration. The DRG and BRG will be stimulated in such a way that there will be an increase in the alveolar ventilation. So there will be uptake of oxygen and there will be an increase in the oxygen level in blood. So hypoxia is corrected via all these processes. So this is the same diagram where we show the peripheral chemoreceptors location. So transport of oxygen in blood. This is a very important, actually a very important thing that we should all know in order to understand hypoxia, in order to understand why there is hypoxia in many patients. In order to understand everything about oxygen, we have to know how it gets traveled inside the body. So before moving on all those things, the very first step of transport is oxygen should be taken up from the lungs into the arteries. So the arterial oxygen content is actually a combination of two different ways. One form, there will be hemoglobin combined with oxygen. Another form, there is also dissolved oxygen. Although this dissolved oxygen forms only like 0.3% of the total content in the arteries, still it is the only thing that reflects the arterial oxygen partial pressure, that is PaO2. So the remaining majority will be the hemoglobin combined form of oxygen. So what is this term oxygen flux denotes? Oxygen flux is actually the amount of oxygen leaving the left ventricle in a single minute. So that this CaO2, it implies the arterial oxygen content. So it is a mixture of the hemoglobin combined form along with the dissolved form. So this plus mark separates the Hb content with the dissolved content. So actually the Hb content is split into this formula like what is the Hb of the patient into the oxygen combining capacity of the hemoglobin, which is in normal patient, it is 1.34 ml of oxygen per gram of hemoglobin, into the saturation of oxygen plus PaO2 into oxygen solubility, and this oxygen solubility is normally 0.003 ml of oxygen per 100 ml of plasma. So whenever you consider the arterial and the venous blood, the oxygen content in the arteries is around 100, whereas in venous it is only 40 millimeter of mercury. Similarly, the amount of oxygen that is carried by the blood in the arteries is 19 ml. The artery carries the oxygen, it will give up to the peripheries. So nearly 5 ml of oxygen is taken up at the periphery level, and when we compare the venous blood, it has the only remaining 14 ml in 100 ml of blood. So the saturation will be in arteries it is 98%, whereas in venous only 75% of HP will be saturated with oxygen. So coming to this is the ODC curve on the left side. It is a plot of oxyhemoglobin saturation versus PO2. So it is a sigmoid shaped curve normally. So actually very important terminology in this is P50. What is P50? It is actually the partial pressure at which the hemoglobin is 50% saturated with oxygen, which means here it is 50% it is saturated at a partial pressure of what? So when you plot this 50 against the x-axis, it comes around 27 millimeters of mercury, which is actually the P50 in a normal adult. So whenever we say there is a shift to left in the ODC curve, it means the P50 is declining towards the negative side. That is, it is declining from 27 value towards a decreasing 10. So when all this left shift can occur is, these are the examples. Whenever there is hypothermia, whenever there is alkalosis, and there is a decreased 2,3 DPG, there is a leftward shift in the ODC curve. So whenever we say that there is a right shift in the ODC, it means P50 is increased from 27. So when all does this right shift occurs? So in hyperthermia, acidosis, and in increased level of 2,3 DPG, we have a right shift. So whenever we tell that there is a right shift, there will be more of oxygen release. Whenever we say there is a left shift, there will be more of oxygen uptake with a decrease in the oxygen release. So how does this affect, like when you can see, as an anesthetist, we have to transfuse more amount of blood intraoperatively, like whenever there is a huge amount of blood loss. So whenever we are using, we all know that blood is stored with certain like adenine, citrate, dextrose, phosphate. So there are we can classify the blood, stored blood based upon what contents we are adding for the preservation. So like in a ACD blood, that is adenine, citrate, dextrose blood, the DPG will fall it will fall even in the first week. And when you see a stored blood, like after 2 to 3 weeks, if you are using an ACD stored blood, we are transfusing into a patient, the DPG will almost be at a 0 level. So whenever there is a decrease in the 2 to 3 DPG, there will be a leftward shift, which means there will be only an oxygen uptake, whereas there won't be any oxygen released to the peripheries. There is no use when there is only an oxygen uptake and there is no release to the periphery level. Still, the peripheries will face, that is, there will be cellular hypoxia when you use a stored ACD blood and transfuse it to a patient like after 2 to 3 weeks. So that's of no use. So that's the advantage in a PCD blood. Like even after 2 weeks, the DPG will almost be a near normal, and only after 2 weeks it will start declining. So it's better if you only have an old blood, like 2 or 3 weeks old blood only we have, then it's preferably to use a PCD blood rather than an ACD blood. because ACD blood can lead to cellular hypoxia. So that's the only issue. 1 second. So coming to the next slide, which is the carbon dioxide transport. So carbon dioxide is present in its highest concentration in the mitochondria. Carbon dioxide has to be carried from the periphery level and it has to be exhaled via the lungs. So it also needs to get transported via the blood. So like we saw in oxygen, similarly there are also forms of oxygen carbon dioxide transport. So here the dissolved form is around 5%. Along with the HB, that is the HB bound form is only 5% here, whereas the bicarbonate form only forms the majority, like 90% of carbon dioxide is carried in the bicarbonate form in the blood. So this is a hamburger effect, which like it shows how the carbon dioxide is taken from the peripheries into the RBC, and at the same time the oxygen gets released at the periphery level. So you can see this is the RBC. This is the tissue from which we are taking carbon dioxide and we are finally giving oxygen. So inside this whole mechanism occurs. So now first let me start with the carbon dioxide is taken, it combines with water to form H2CO3, which in turn splits to form H plus and HCO3 minus ion. So this H plus, this H plus will bind with the hemoglobin, that is oxyhemoglobin. Thereby the oxygen gets released finally. Or there is also another mechanism where carbon dioxide combines directly with the oxyhemoglobin and it will release the oxygen to the plasma, that is at the periphery level. So this overall terminology, this overall mechanism is called as a hamburger effect, which is also known as a chloride shift. So this occurs at the periphery level, it's not at the lungs. So you should know this effect. Any doubts so far? If you have any, please leave a message in the message box so that I can reply to all your doubts. At the end of the session, we will have a clarification of all the doubts. So actually, this is just, that like in chronic lung disease patients, some patients will have they are always dependent on oxygen. So they always used to carry a portable oxygen cylinder with them, and via an oxygen cannula, it is a nasal cannula, they always are dependent on oxygen. So all these patients, they won't have hypoxia. So their respiratory drive to hypoxia will always be suppressed because they are always on oxygen. So their only drive will be hypercarbia. Okay. So coming to the respiratory mechanics, actually, whenever we have the term respiratory mechanics, we should know certain terminologies that are thorough. So these terminologies only will further explain more about the physiology of respiration. So in order to be strong with the basics, we have to know certain terminologies like compliance, resistance, elastance, inertia, the compliance curve. So all these are basics which we have to be very, very strong. So the first terminology among them is the compliance, and compliance is actually a measurement of the elasticity of the lungs and the chest wall. It can be defined in a equation like it is the change in volume divided by the change in pressure. So the normal compliance is 0.2 to 0.3 ml per centimeter of water change in transthoracic pressure. Like what is transpulmonary pressure means? It is the airway pressure minus the pleural pressure, and compliance will be low. Like whenever FRC is low or whenever FRC is very high, at both the extremes, compliance will be low. So we have to maintain a normal FRC in order to achieve a maximum compliance. So this is actually the compliance curve. We have plotted lung volume against y-axis and the pressure change against the x-axis. So you can see my cursor move, like this is the inspiration process and this is the expiration process. So during inspiration, the pleural pressure falls even more negative, whereas the lung volume is increasing. in inspiration. During expiration, you can see the lung volume decreases, and at the same time, the pleural pressure becomes more towards the positive side. That is, pressure becomes positive during expiration. Pressure becomes even more negative during inspiration. So this is a normal compliance curve. So these are just a few points like about compliance, like which the lung portion which undergoes the maximum expansion will be the peripheral parts of the lung, which are in direct contact with the chest wall, rather than at the center portion. That is the hilar portion of the lungs. They will have a comparatively lesser compliance when you peripheral portions will have more compliance. And similarly, the base of the lung will undergo the greatest expansion. That is that part of the lung which is in contact with the diaphragm. So what are those surfaces which do not expand directly? Means they are the mediastinal surface, the posterior apical surface, and the dorsal surface. Usually, the upper thorax will expand more in the anteroposterior direction, whereas the lower thorax will expand more in the transverse diameter. The anteroposterior in the upper thorax. In the lower thorax, it will be the transverse diameter where the compliance will be maximum. So this is actually an example. We see a lot of athletes, not only athletes, even us after walking fast or after running for very few yards also, we usually prefer to adopt this posture, as you can see. So see, in this picture, these are athletes after running, they adopt this posture. This is a similar posture we are all familiar with because we also usually adopt such postures. Similarly, some lung pathology patients, whoever are dyspneic, they are tachypneic, they usually prefer to be sitting in this posture with the, like what we say, this is actually a tripod posture. It's looking like a triangle here, right? So this is a tripod posture. So why are these patients or even us, why are we preferring this type of posture rather than a sitting posture after running? Because in this posture, we have a decreased pulmonary congestion. We have the maximum accessory muscle usage in this position. The length tension curve of diaphragm is favored. It reduces the work of breathing. So without even knowing all these things, we naturally tend to adopt this tripod posture because that will be the easiest one that will be relieving our dyspnea at that type of situation. So this is a combination of all the volumes and capacities in a single diagram. So you can see this is the normal tidal volume, the volume of air that we normally inhale and exhale out of the lungs. This is the tidal volume. The maximum volume of air that can be inhaled after a tidal volume. So this is the inspiratory reserve volume. Whenever we add tidal volume with the inspiratory reserve volume, that becomes the inspiratory capacity. So the maximum volume of air that can be exhaled after a normal tidal volume is the expiratory reserve volume. Please follow my cursor wherever I'm moving. So this is the expiratory reserve. When we add tidal volume with the expiratory reserve volume, so this whole length will become the expiratory capacity. When you add inspiratory volume, tidal volume, and expiratory volume, so this whole length will become the vital capacity. The residual volume is the volume that is left behind in the lungs even after a maximum expiration. So when you add residual volume along with the vital capacity, that becomes the total lung capacity. So now what is this FRC? It's actually an addition of the expiratory reserve volume along with the residual volume. These together contributes the FRC. So the same written in words with the average normal ml. So tidal volume averages 500 ml in a normal adult. Inspiratory reserve is 3000 ml. Expiratory reserve is 1100. Residual volume is 1200. So this total lung capacity adds to nearly 6 liters. Vital capacity 4.6 liters. FRC 2.3 liters. Okay. So this is a slide that explains everything about FRC, which is functional residual capacity. So it is actually a static lung volume. The volume of air that remains in the lungs after a normal tidal volume, that is only FRC. So FRC keeps increasing with height. Actually, in old age, FRC is more. Why is FRC so important? There are two reasons why FRC is important. So actually, inflating an open lung is very easy. So if you imagine at the end of expiration, if the alveoli collapse like this, it's very difficult to open it again during the next inspiration. Whereas at the end of this is inspiration, and at the end of inspiration, if the alveoli is only this much, it is already a little open. So it will be easy during the next inspiration to dilate this. So that is what is written here. Inflating an already open lung is easier because the air-liquid interface will have a decreased tension rather than a liquid-liquid interface. That is, when the alveoli is collapsed, there will be a liquid-liquid interface. When the alveoli is a little open, it will have an air-liquid interface with a less surface tension, which will be very easy. That is why the FRC is important. So this is the first point. The second point, like whenever actually the perfusion is almost continuous, in the pulmonary blood flow will be always continuous. So ventilation, when the ventilation is interrupted, there are times where the pulmonary blood flow will leave the lungs even without getting oxygen. So whenever the ventilation is continuous and the perfusion is continuous, the pulmonary blood will always carry oxygen from the lungs. It will get oxygenated and then it will leave the lungs. But whenever ventilation is intermittent, only the perfusion is continuous, then there will be many time period where it won't take up the oxygen. So the deoxygenated blood itself will enter the left side of the heart. So in order to have prevent a major oxygen desaturation, we always need this ventilation to be continuous. So that's why the FRC will be remnant always, which with a certain amount of oxygen that will provide the pulmonary blood with oxygen even during the expiration process. So we already saw that with height, with age, the FRC is increased. So when does this FRC will decrease? In supine, prone position, in women when compared with men, in pregnant women rather than normal women, in obese patients, in restrictive lung diseases. So in all these patients, FRC will decrease, which means they are very much prone to hypoxia. They are very easily accessible to hypoxia. Okay, so that's a lot about FRC. Now coming to the terminology airway closure. So it's a concept like what to say. Airway closure is only a normal phenomenon, but when it occurs at a little earlier stage, then it will become abnormal. So small airways, not the major airways like the trachea or bronchi. We are talking about the very small airways, the terminal bronchioles. At that level, they don't have any cartilaginous support. They only depend upon the radial traction, which is caused by the elastic recoil of the surrounding tissue to keep them open. So during expiration, the volume of the So this airway closure, that will be, that is the closing volume will be there. The closing volume along with the summation of the closing volume along with the residual volume. Residual volume is what we saw in this, you can see. So that residual volume when added with the closing volume will contribute to the closing capacity. Closing capacity is only a normal phenomena, but it is raised in smokers, obese patients and in bronchitis. So yeah, actually, in supine, FRC will decrease, but the closing capacity will remain the same. Okay, so FRC decreases, but closing capacity will remain the same. So in old age, this closing capacity will occur a little earlier, either at or above the FRC itself, this closing capacity will occur. That is very, very dangerous, which with people getting more prone to hypoxia. Okay. So this is actually a plot of this volume against this pressure. So this is the normal lung. Like in a normal lung, whenever the pressure, you see, you can see the volume. The volume is like this when the pressure increases. In fibrosis, what does this denote is that the volume will never increase. Because it is a restrictive lung disease, the lung volume will always be at its minimum level. Whereas when you see the obstructive lung disease like COPD, asthma, emphysema, the volume will actually be at a higher level. In asthma and bronchitis, the volume will be at a higher level when you compare with the normal lung. In emphysema, even with the minimal change in pressure, the volume is at its maximum, already it is at its maximum peak, even with a very minimal change in pressure. So in fibrosis, only when you put a maximum effort, like when the pressure changes like this much only, this volume is rising from 1 to 2. It is very, very high. The patient has to strain a lot in order to fill his lung with this much volume. He has to strain, put this much pressure. Whereas in obstructive patient, the pressure need not be this much, but already it is filled with the lung air already. Okay, so obstructive lung diseases, there will be air trapping already during expiration. The expiration won't be complete. The FRC will be more in obstructive lung diseases patients. So this is the terminology. Another terminology like compliance, we are coming to airway resistance. Normal resistance is 1 centimeter of water per liter per second. It is increased in asthma COPD patients. When you have any ET tube of a smaller size, like if you are going to intubate a patient, the normal ET tube size that is required for the patient, let it be like 8.5. But we are putting only a 6.5 tube for that patient. Then his airway resistance is increased. So similarly, whenever there is a bed unidirectional valve, whenever we are using L bends, the resistance will increase. And maximum resistance will be at the larger airways, but the maximum contribution, that is 80% impedance, is at the larger airway. Maximum contribution is by the medium-sized bronchi, that is before the 7th generation. Actually, there are two things that control resistance. That is, one is the flow or the volume of air. I mean, there are two things, like there is volume-related collapse, there is also a flow-related collapse. What does this resistance do? It will impede the airflow. So in order to overcome resistance in a spontaneous breathing patient, this pleural pressure will be the driving pressure to overcome the resistance. In a positive pressure ventilation, like when we are putting the patient on ventilator, this is the airway pressure minus the alveolar pressure, which helps in overcoming the airway resistance. So when you see this volume-related airway collapse, at a lower lung volume, there will be loss of radial traction. So there will be easily collapsed. Low volume, easily collapsed. In a flow-related airway collapse, like whenever we are forcefully exhaling, forced exhalation, there will be positive pleural pressure. There will be a large pressure drop across the airway. So that will lead to a sudden collapse. Okay. There are two types of flow that we should know. Normally, in physics, we would have learned like this. So there are laminar flow and turbulent flow. Laminar flow, the resistance formula is 8 eta L by pi r power 4. Whereas in a turbulent flow, the resistance is flow into gas density divided by radius power 5. So actually laminar flow will occur distal to the smaller bronchioles. That is, in the smaller airways, we have laminar flow. In the bigger airways like trachea and bronchi, we have the turbulent flow. So how can we reduce the resistance in a laminar flow? It is by reducing viscosity. In a turbulent flow, this can be lowered by reducing the density, because density is directly proportional to resistance. Here eta, this eta, that is viscosity. Viscosity is directly proportional to resistance. So when you reduce viscosity, resistance decreases. Here when you reduce density, resistance decreases. So actually in upper respiratory obstruction, that is whenever the turbulent flow is high, in whenever there is an upper respiratory tract obstruction, we use Helios for such patients. Why does we use Helios? Because it has a low density. So what is the use? Whenever we are using a low density, we are reducing the resistance. Okay. So this is a mechanism by which the COPD patients adopt to overcome the resistance. They use this pursed mouth breathing. So they are prolonging the expiration process by pouting their mouth to increase their expiratory resistance at the level of mouth. So whenever they are going for a pursed lip breathing, their expiration process is prolonged, so there won't be any air trapping. Expiration process, whenever it is prolonged, we have time to exhale a lot, so there won't be air trapped at the end of expiration. Similarly, there will be open airway due to the pressure created at the level of the mouth. That pressure will help in maintaining an open airway at the throughout expiration process. So that open airway, because of that, the air will be getting expelled from the alveoli. So that helps in COPD patients. This is actually an adaptive mechanism that COPD patients follow. So coming to the next terminology, which is the elastance. So surface tension, elastance, they all go hand in hand. Lungs and the chest wall, they all have their elastic property. Why is the elasticity high? Because they have high amount of elastin fibers. Surface tension, we have, it is a terminology that plays at the level of the alveoli. So there is an air fluid interface in the alveoli where the surface tension occurs. So according to Laplace law, the pressure is twice the surface tension divided by radius. So what is the God-made thing that helps in reducing the surface tension in our alveoli? It is the pulmonary surfactant. What is the role of pulmonary surfactant? It prevents the smaller alveoli from getting even more smaller. At the same time, it prevents the larger alveoli from getting even more larger. That is the application of Laplace law. So now coming to the next terminology, which is the work of breathing. So the factors that we have to overcome, now we are respiring, no, we are ventilating. We have to overcome a lot of forces in order to make this work of breathing feel a little, what to say, we are not, we have to breathe continuously, but we need not put so much strain on that breathing. So we are not feeling dyspneic because of breathing. We are utilizing a lot of work in the ventilation process, but still we are not feeling weak. We are not losing our energy. So our work of breathing is kept at its lowest. So that is what we are going to talk about here. So we have to overcome certain forces in order to breathe efficiently. So those are the elastic recoil of the chest and the lung, the frictional resistance in the airways, and there is also tissue resistance. So overcoming all these only, we are moving our air inside the lungs, we are moving the air out of the lungs. So what is this work of breathing denote? It is the pressure into volume. So like whenever the tidal volume increases in a patient, whenever we have to increase the tidal volume, the work required to overcome the elastic resistance will increase. Whenever the respiratory rate increases, the work required to overcome the airflow resistance increase. So we should have a normal tidal volume and a normal respiratory rate. Whenever we are going in for tachypnea, or whenever we are in need of a larger tidal volume, it means our work of breathing is increased. Then we will feel the difficulty of breathing. We will have dyspnea, we will become dyspneic, tachypneic, everything. So we will feel tired at a point of time. We will face hypoxia. So that is what this work of breathing denotes. So this is a plot of change in lung volume versus the change in pleural pressure. We have already seen this. This is the compliance curve. So this is the inspiration process, and like this occurs the expiration, as we already saw. So with this inspiration alone, when we compare, the work of breathing done by against the airway resistance work is denoted by this orange color. The work of breathing against the tissue resistance is violet. The work of breathing done to overcome the compliance is this green. So the compliance work is more. Okay. So like in a restrictive disease patient, the elastic resistance is increased. So what does this patient they adapt like in fibrosis? When you see a fibrosis patient, they usually have rapid shallow breaths. They will be tachypneic, but their breaths will also be shallow. So why are they adapting for this? So that is the adaptation at which their work of breathing will be at its minimal. So that is the adaptation of a restrictive disease. We will see now. So this is a normal patient. In a normal patient, this is the elastic resistance, this is the airflow resistance. So at a point when this both resistance is its minimum, so elastic resistance is high at a respiratory rate of 5, whereas elastic resistance is very low at 20. But airflow resistance is very low at 5, it is at its highest at 20. So in order to have a minimum of both, we have to see at a point where these both interfere. So at a point where these both meet, the respiratory rate is around 15, which is our normal respiratory rate, 12 to 16. So when we adopt, we are going in for a 12 to 16 respiratory rate, we are having the total work of breathing at its minimal level. So this is a normal patient. Whereas when you see, whenever there is an increased elastic resistance, that is in restrictive disease patients, their elastic resistance will be very increased. So at a point where this elastic and airflow resistance should meet, it will be only at a higher respiratory rate. That is, the work of breathing is at its lowest level when you go in for a rapid shallow breath. So this is a restrictive disease patient. Now when you see a obstructive disease patient, their airflow resistance will be very high. So when you adopt a 15 respiratory rate, you have to go in for a higher airflow resistance. So your work of breathing will be high. So such patients, they usually adapt for slow, deep breaths. They usually reduce their respiratory rate. Why? They have their respiratory rate usually around only 8 to 10. That is because only at that point of time, their work of breathing is very low. So you can see in this third graph. At a point where the elastic and airflow resistance meet, the respiratory rate is very low. So in order to decrease their work of breathing, in order to have a minimal work of breathing, in not get tired, these COPD patients, they adopt for slow deep breaths. So we all know that tidal volume is a combination of alveolar ventilation along with the dead space ventilation. You must have all read this in your first year MBBS physiology. So just a comparison of what occurs at the apex as well as at the base of the lung. At the apex is usually always aerated. Even during inspiration, when the air enters, it is already aerated. So it will have only less resistance. It means like it is already open. So there will be a resistance will be less. So compliance will also be less because already air is filled. You can fill in only a little more of air inside. So compliance is less. There will be a more negative pleural pressure and a higher transpulmonary pressure. Whereas in the base of the lung, it's usually only less aerated. So air will be less in the alveoli. So there will be more room. You can fill in more air. So it's more compliant, but at the same level, it has a higher resistance. Because when it is at less aerated, you have to force in. You have to put in more effort in order to open this alveoli out. And there will be also a less negative pleural pressure. So when you see this dead space, actually dead space concept you must all understand to the core. It's not all the inspired air will enter the alveoli. So there are also air that gets that always stays in the only in the transporting pathway. That is, it will stay only in the trachea and bronchi. That will never encounter with the ventilation process. It will never go in for an exchange. So whatever air you are inhaling, whatever that stays in the trachea and bronchi, that will be contributing to the anatomical dead space. And at the same time, you must also understand not all the air that enters the alveoli will always involve in the gaseous exchange. So there are certain amount of fat that will enter the alveoli, but will never take part in the gaseous exchange. So that will contribute to the functional dead space. And a combination of both will be the total physiological dead space. Normally, 33% of tidal volume will be only dead space. That is normal. You need not worry about that. But when and as the age increases, when we are getting older, this dead space also will get more and more. And during anesthesia, whenever we are intubating the patient, we are connecting to a ventilator, we are actually we are increasing more dead space to the patient, because whatever air is filled in this trachea, that is in the endotracheal tube, up to the L-bend at the point till the where the that is when till the point it gets connected to the ventilator circuit, that will also contribute to the dead space. So in general anesthesia, we are increasing the dead space of the patient. That also we should know. But just let's talk about the normal thing. Like a normal dead space is 150 ml. That is 33% of tidal volume. That is 2 ml per kg. So there are apparatus dead space, anatomical dead space, physiological dead space, functional dead space. So all these terminologies you should be familiar with. And we should also know what are the factors that keeps affecting this dead space. Like in general anesthesia, this deals with more like whenever we are giving positive pressure ventilation with the age of the patient, in an upright posture, actually the dead space will be more rather than when you are lying flat. And similarly, neck extension will increase the dead space rather than neck flexion. Okay. So we have finished with ventilation. Now we are coming to the perfusion. So pulmonary circulation is unique in its own way. You can see in this thing, like the pulmonary blood vessels, they are short and they are very wide. So their pulmonary pressure will be less. The resistance will be very less. It's actually a pulsatile flow. And actually, you should know this concept that hypoxia will lead to vasodilation throughout the body except the lung. Only in the lungs, hypoxia will lead to vasoconstriction. That is a terminology called hypoxic pulmonary vasoconstriction, which we will also deal with in the last slide. Okay. So the blood flow at the apex of the lung will be only 0.07 liters per minute, whereas at the base it is 1.29 liters per minute. So which means perfusion is more at the base rather than the apex. It's more of a concept of gravity only. So there are West zones. We classify the lungs into 3 zones. That is the West classification, but later on Hughes he modified the West zone into 4 zones totally. So these are actually, how are we classifying these zones? They are based on the pressures. When we are comparing the alveolar pressure, pulmonary artery pressure, pulmonary venous pressure, and the interstitial pressure. So based on a comparison of all these, whichever is the highest. So according to that concept, we are classifying the zones of the lung. So whenever the alveolar pressure is more, where the alveolar pressure is more, it is at the apex. The pulmonary artery pressure will be more towards the base. So that is how we are classifying. So when you move from the apex of the lung towards the base of the lung, the alveolar pressure will keep decreasing, whereas the arterial pressure will keep increasing. And this zone 4, that is the basemost part of the lung, that is the region where pulmonary edema or atelectasis is very common, because that is the area where the arterial pressure is very, very high. Okay. Now we have seen ventilation and perfusion separately. Now we are comparing both. That is ventilation perfusion ratio. So this is denoted by the V by Q. So V by Q is normally 0.8. You can see here the normal ratio of a VQ is 0.8. So actually this is the base of the lung. This is the apex of the lung. So whenever we are moving from the base towards the apex, the ventilation is same. You can see the ventilation falls. Whenever we are moving from the base of the lung to the top, you can see the blood flow decreases. Actually, ventilation decreases, perfusion also decreases, but perfusion fall is very, very wide. There is a wide difference when you compare the perfusion at the base as well as at the apex. Ventilation, there is only a narrow change or a narrow difference when you compare the base and the apex. So actually, the V by Q at the base is 0.63, whereas at the apex it is 3.3. And whenever we are telling that V by Q is 0, we are mentioning that ventilation is 0, but perfusion is there. So perfusion is present, but ventilation is not there, which means like even we can tell about the trachea and bronchi. There is ventilation. That is, ventilation is not there, but there is perfusion to the trachea and bronchus, right? So that contributes to the dead space. That is an intrapulmonary shunting. Sorry, I'm very sorry. Like whenever we are telling that V by Q is an infinity, that is 1 by 0, we are telling that there is no perfusion, only ventilation is there. That is the region, like we are comparing trachea and bronchi. Trachea and bronchi, we have ventilation there, but we don't have a perfusion there. That is, for gaseous exchange, we don't have a perfusion. That is, pulmonary artery is not present there. So trachea and bronchi, whenever we are talking about dead space, that V by Q is infinity. Whenever we are telling that V by Q is a 0, then we are telling that ventilation is not there, but perfusion is there. So there are regions of the lungs where there can be a alveolar collapse, there can be a fibrosis, there can be pulmonary edema, that is the alveoli is filled with fluids. So that point of time we cannot have ventilation, but perfusion is still there. So that is the point where the shunting occurs. Shunting is when there is no ventilation, but perfusion continues. So the pulmonary blood will leave the lung without even carrying oxygen along with it. So it will enter the left side of the heart without carrying oxygen. The deoxygenated blood will enter the left side of the heart. So that is the theory where we are calling there is an intrapulmonary shunting. Shunting means deoxygenated blood will enter the right from the right side of the heart towards the left side of the heart. So venous admixture. So normally it is 5% of the cardiac output. Venous admixture is a normal phenomena only, but when it occurs more than normal, then it will lead to then it is disastrous. So venous admixture, blood which has passed from the right side to the left side of the circulation, but it has picked up no oxygen. That is a true shunt. So there can also be certain situations like blood which has picked up some oxygen, but it's not fully oxygenated. So it is either passed through an overperfused or an underventilated zone. That is a low VQ ratio. So that is also a venous admixture. So there are a variety of shunts present, like anatomical shunt, physiological shunt, pathological shunt, atelectatic shunt, etc. So physiological shunt, so those are normal mechanisms like the Tabasian veins and the bronchial veins. They drain into the left side of the heart, so they are physiological. 5% is normal only. Whereas like whenever we have a ASD or a VSD, whenever there is a pathological due to congenital heart diseases, whenever there is a mixing of the right and the left side of the blood, then that will lead to a pathological shunt. That is an extra amount of shunt blood that is added. So that will be pathological. So normally 2 to 3% of the cardiac output can be a shunted blood, but in pathological states it can reach like even 50% of blood can be deoxygenated that enters the left side of the heart. So this is the same actually. So there can be low VQ, there can be shunting also. Shunting, complete cessation of ventilation, whereas low VQ, it has taken up some oxygen, but it is not normal. It's not up to the maximum level. So low VQ can occur in lung diseases, COPD, asthma, vascular diseases. So in that conditions, whenever you supplement oxygen, this low VQ can be corrected. Whereas when you see a shunt, it's actually a complication. Even when you give 100% oxygen to a patient in shunt, it will not completely correct the shunt. Okay. So this is a terminology like I already said, hypoxia will lead to vasodilation in all the areas except the lung where it leads to vasoconstriction. So it's a hypoxic pulmonary vasoconstriction. It's actually a very safe mechanism. It's a compensatory mechanism that diverts blood from hypoxic areas towards the more oxygenated areas. So you can see in this picture. So see, this is a hypoxic alveolus. So there won't be oxygen inside this alveolus. This is a normal alveolus. There is a plenty of oxygen in this. So blood is getting diverted towards the normal alveolus. Blood is getting diverted away from the hypoxic alveolus. So wherever there is hypoxia, there is vasoconstriction. Ventilation is less, perfusion is less. V is less, Q is less. So VQ is normal. Ventilation is more, perfusion is more. V is more, Q is more. So when both VQ are increased, then the ratio remains normal. So in order to maintain the VQ ratio, this is an adaptive mechanism. So what is the stimulus here? Hypoxia is the stimulus. What is the result here? Shunting. That is vasoconstriction is the result here. What is the advantage? We are reducing the shunt. Okay, but there are also plenty of disadvantages, like whenever the patients are exposed to chronic hypoxia. So like high altitude patients, they whenever they are going in for vasoconstriction over a prolonged time, there can be a pulmonary hypertension in such patients. So there are also disadvantages in this. So just a question session. I would like to ask this question. A 5 kg weight is placed on the chest as well as in the epigastrium. So what do you think which will cause more impedance to the ventilation? A 5 kg weight placed on the chest will be more impeding, or a 5 kg weight placed on the epigastrium? So I would like everyone to answer to this question in the message box so that I could reply to your answers. So I could see a few answers here saying a 5 kg on the chest will be more impeding. You could also see few answers on the epigastrium. Okay. So let me tell the answer. Actually, you will all think that a 5 kg weight placed on the chest will be more impeding, but it's actually a 5 kg weight placed on the epigastrium will be more impeding to the patient, because the diaphragm is the most important muscle which is involved in the respiratory process. And a 5 kg weight placed on the epigastrium will be more impeding to the diaphragmatic movement. So whichever is impeding the diaphragmatic movement, that will be more impeding. So a 5 kg on the epigastrium is a very difficult one for the patient rather than a 5 kg weight placed on the chest. So that comes to the end of the slide. Thanks everyone for the response. And that will be the end of our class. Thank you everyone.